not even internet. I think it was in a very primitive state. There's so many things that can be done today. So many opportunities are there, and I think it's. And I'm not trying to give a gyan here, but I think it's really practical, and we understand that we have to grab these opportunities because medical profession is really hard in our country. There's too many doctors. I mean, they all say that the lack of doctors, but all the doctors want to get into urban and corporates and whatnot. So that the competition is extremely high. So unless we do something unique, unless we do something different from others, we will not stand out. So I think lots of new things that can be done these days. We should change with times, adapt with technology. Medical technology is just changing dramatically. AI, VR, 3D printing, medical devices, and so on and so forth. So it's all increasing.
That is true. The meeting is now live on YouTube, and I think it's already 5:03, and we can begin in another 2 minutes.
How would I share that on my Facebook? Would I be able to do that?
So I can share the YouTube link with you, and you can share that link. It's going to be broadcasted live, and it's going to be saved after that also.
Okay, right, that's fine. Why is Akansha very quiet? Because she was pestering me after this talk for a long time. And then somehow we got this together.
Sir, I was listening to what you and ma'am were talking about.
I think we can begin now. Kansha, over to you.
Thank you, ma'am. Yeah. So, a very good evening to everyone. This is Akanksha Singh, project head of Pact to Protect, along with Sandhya Monga, the director of public health and research department, Parikshit and Shrishti, the project officers for the project, and Sahil, the project coordinator, as the core team. We welcome you all to DefeatHep. Together, we can. Our workshop will consist of a series of webinars led by distinguished speakers allied with World Hepatitis Alliance and Chennai Liver Foundation. From taking a close look at liver transplant surgery to diving into the epidemiological aspects of hepatitis, we have it all covered. Before we begin the workshop, I would like to give a brief introduction about AMSA and Public Health and Research Department. The Asian Medical Students Association International is the peak representative organization for medical students across the Asia Pacific and beyond. Its multinational activities serve as platform for students to share knowledge, undertake activities that benefit local and international communities, and thus create and maintain transitional friendship. The Public Health and Research Department of AMSA India aims to provide opportunities to Indian medical students to work on various public health projects, which is in line with the United Nations goal, thereby serving the society as medical volunteers. Now, I would like to request Shrishti to take over and introduce the speaker for our event today. Shrishti,
Right.
over to you.
Thank you so much, ma'am. Our expert speaker, Dr. S. Vivekanand sir, is a hepatobiliary and transplant surgeon at RPS hospitals and is also the managing trustee at Chennai Liver Foundation, which is associated with the World Hepatitis Alliance. Chennai Liver Foundation is a voluntary non-profit organization which aims to promote awareness about liver health by supporting research and educational activities. It also offers help and support and information to the medical fraternity and to the general public about the diagnosis, prevention, and treatment of liver-related disease. But its main focus is to make treatment of liver disease affordable. Sir has been involved in over a whopping 750 transplants and multi-complex hepatobiliary surgeries, and has published over 40 papers in national and international journals. In addition to that, he also has extensive teaching experience through both national and international workshops and conferences. We are thrilled to have you, sir. It's an absolute pleasure. All of us are really excited for this today's session, which I'm sure would be incredibly informative and interesting since we don't really get to hear about this perspective when we usually talk about hepatitis. The stage is yours.
Lovely. Thank you very much. And I'm delighted to be talking on a Sunday evening. I'm delighted. I'm not sure about you, though, not listening on the other side. But yes, as I was just saying before, I haven't heard of many medical students association, and I'm thrilled to know that there are multiple verticals, and there's a director of public health, and there's a project officer, trying to do something which is really nice and inspiring. I think hepatitis has been a big subject, and I've worked a fair bit in hepatitis, and we're still doing it. Chennai Liver Foundation is an organization which my father founded, and then I'm running it as of now to eliminate and to prevent elimination. I'm sorry, to eliminate viral hepatitis and prevent liver diseases in particular. Because I'm a transplant surgeon, so end of the day, I'd like to make a transplant affordable. As you know, it's running into lakhs these days. I think it is slightly expensive. Even yesterday, I was giving a talk, and the first question asked me is, why is transplant expensive? So we can't make it into single digit numbers, but otherwise we can definitely reduce the cost of transplantation. That is what we are striving at. So today, let me just share my screen. Right. Can you see my screen? Yeah.
Yes, sir.
Yes, sir.
Okay. So, as you can see, Chennai Liver Foundation is the organization which I come from. Of course, I work in a couple of hospitals. I run my own hospital, and then a couple of other hospitals. I run the transplant program for them. The World Hepatitis Alliance is a body which is supported by the World Health Organization, which is based out of London. And of course, the registered office is in Switzerland, but they're based out of London, which works for the elimination of viral hepatitis. It is a patient organization where all the board members are patients actually of viral hepatitis. They have so the organization has got multiple offices around the world, and they have over 200, 300 members, all of them working against viral hepatitis, and they are constantly growing. So it's an amazing organization. They do a lot of work for viral hepatitis, and the movement to eliminate viral hepatitis is called NoHep. Okay, that is the movement which the World Hepatitis Alliance has adopted. Okay, so I think I did mention this to Akanksha sometime, and maybe just she didn't notice that. But DefeatHep, we should have some uniform code. So instead of introducing a new term, so if you adapt terms which are internationally recognized, then you'll be recognized very easily. When you tag NoHep, hashtag NoHep, then they'll get to know that you guys are doing an amazing job. So I think my suggestion to you is to adopt NoHep. And of course, I've also written to them. I think they've already done a tweet this morning tagging you and my foundation about this whole webinar, and they've sent a word of appreciation also. Okay, so why hepatitis? A lot of people are wondering why are we talking about hepatitis. There's so many other things. I mean, this year has really been all about COVID, and every other disease has taken a backseat. But we need to understand that this is the 7th leading cause of mortality. Okay, in the 1990s, this was the 10th leading cause of mortality. But now, and by 2010, 2012, it became the 7th leading cause of mortality. And you'll be astounded to hear that close to 1.4 million die every year. That's a staggering number, 1.4 million, and it was that comes to about 4,000 a day. That's quite a big number dying every day. Of course, now, viral hepatitis, you need to understand that viral hepatitis does cause cirrhosis liver. Viral hepatitis, the virus itself is an oncogene, which means that it's a cancer-forming gene. So hepatitis B and C can cause liver cancers. Interestingly, all liver diseases, most of the liver diseases can be prevented and controlled, and so is viral hepatitis. For example, if you don't drink alcohol, you're not going to get alcoholic liver disease. If you're going to be healthy, avoid fatty food, exercise regularly, you're going to, you will not have fatty liver disease. Likewise, if you get tested for hepatitis B and get vaccinated, if you drink clean water and clean food, you will not get hepatitis A or D, so on and so forth. So this is completely preventable, and of course, it can be controlled and treated if required. So we know now, though, that there is vaccines for hepatitis A and B. There is good treatment available for hepatitis B, and there is a cure available for hepatitis C. There is a difference between treatment and cure. Okay, but it's one of the very few viruses where cure is available, and Hep C in the last, I think, 2-3 really revolutionized the treatment. So, because the number of people who are dying is quite big, the WHO suggested in one of their Sustainable Development Goals suggested that the hepatitis should be eliminated by the year 2030, and I shall come to that shortly. And again, this is again the WHO data suggesting that the number of deaths happening because of viral hepatitis is going up while everything else is coming down. HIV is coming down, malaria is coming down, and even tuberculosis is coming down. But definitely hepatitis is on the rise, and we need to be working towards viral hepatitis. I think this I've said in the 1990s, it was in the 10th, and then it's moved up to the 7th. We need to remember that cirrhosis patients, or in other words, HCCs happen in a cirrhotic background. Okay, 80% of liver cancers happen in a cirrhotic background, and non-cirrhotic HCCs only happen in about 20% of patients. So that is why all cirrhosis patients, whether it's viral hepatitis, alcoholic cirrhosis, or NASH cirrhosis, or any other form of cirrhosis, they need to have very frequent surveillance just to make sure HCCs don't happen. And if it happens, of course, it can be cured. Transplant is the only option, though, but certainly can be cured. Likewise, viral hepatitis, both B and C, it does cause cirrhosis, but they being an oncogene by itself can cause HCC even in a non-cirrhotic background. So and of course the treatment differs. I'm not going to talk about the treatment of liver cancers now, but definitely the treatment differs for Hep B and Hep C HCCs. Now again, this is a WHO data which suggests that CROs are region, the Southeast Asian region, suggesting that about 4 lakh deaths, or 400,000 deaths a year due to viral hepatitis, and 80 complications of Hep B and C. And that is why the WHO has given us a roadmap as to what needs to be done. Okay, so we are here somewhere there. This is 2015, and by the year 2030, they want a 90% reduction in new cases, and they want a 65% reduction in the number of deaths that is happening secondary to viral hepatitis. I mean, that is a huge task. So the WHO has written, all these things are available online. The WHO has written to every government possible. In fact, the World Hepatitis Alliance convened a summit in the year 2017 where we had representation. Even I was there for the meeting. It happened in Glasgow, where 192 countries participated, and the WHO persuaded all of them to adopt a viral hepatitis control program. And we in India have adopted this program in the year 2018. Having said that, there are a few policies were formed, but I haven't seen anything concrete happening in the last couple of years. Of course, this year is gone. I think every state government has been urged.
The first one was with Dr. Ocean, and this one, Apnika is going to present a paper. So I hope everybody is motivated enough and you'll start participating in the subsequent sessions.
What's happening?
Yeah.
Okay?
Nothing, sir. You can continue. I think someone unmuted them. You can continue.
Right. Okay. So you should understand that health is a state subject in our country. Okay? Though the government of India can have policies, it depends on the state government to adopt these policies. I know a few states have already done that. Punjab has done that. Tamil Nadu has done that. I think Delhi is in the process of doing it. Gujarat is doing it. So likewise, many states are doing it, but a lot of states have still not adopted a viral hepatitis program. So if any of you in that state, and if you have any connects, then you should look at starting such things and persuading the government to start a viral hepatitis program. So viral hepatitis can be transmitted by two major routes. One is a horizontal transmission, and one is a vertical transmission. Of course, hepatitis A and E, we know, are transmitted by unclean food and unclean water. We're not talking about A and E today. We're talking about B and C. So B and C is obviously, it's through blood and body fluids. Blood being, use of any personal items, your razors, your clippers, your any scissors, any personal equipments. Then sharing of IV needles by drug abusers, unprotected sex, multiple sexual partners, so on and so forth. They all form the horizontal transmission group. Of course, tattoos is another group where by sharing of needles, hepatitis can be transmitted. And of course, vertical transmission is transmission of the from the mother to the child. Now, what happens when there's viral hepatitis in pregnancy? It's likely that most of the HPV carriers have a stable viral activity during and post delivery. Okay, few of them will have a rise in their liver function test. Classically, the enzymes is SGOT and SGPT, but some also can have a seroconversion, meaning that they become inactive during their pregnancy. That is because an immune modulation happens in the body for two things. One is obviously they have to prevent the fetal, they have to protect the fetal allograft from rejecting and having an abortion. And of course, the hormonal changes alters the host immune response and may affect the HPV activity during pregnancy. And that is why some of them can seroconvert from HPAG positive to HPEG negative. So why is it important is that it certainly causes a lot of negative impact on maternal health. A being gestational diabetes, preeclampsia, antepartum hemorrhage, preterm weight, low birth weight, and of course need for assisted ventilation post delivery. So what happens? What are the methods of routes of vertical transmission? So it's clearly the mother or the father can be the infected person, and then they transmit the disease to the child. Okay, it can be intrauterine, it can be perinatal, or it can be through the breastfeeding. Obviously, intrauterine is through the maternal tissue as a transplacental transfer when the uterine contracts. The blood from the mother and the placenta can get transmitted to the child. It has been also shown that vaginal delivery associated with a slightly higher rate of infection, though some studies do challenge that. So that is why they suggest that LSCS or cesarean section is a better method of delivery in patients with viral hepatitis, because when the uterus contracts, as I said earlier, blood gets injected forcefully into the child through the placenta and the umbilical cord. There has been enough evidence to suggest that breast milk does have hepatitis B virus. Okay, but there is not evidence to suggest. There is no evidence to suggest that it gets transmitted to the child. There is a higher risk if there is a sore on the breast, if there's an ulcer in the breast, or if the child's has got ulcers or cracks in the lips and the mouth, because at that point the virus may get transmitted. But again, a large meta-analysis has demonstrated that there is no risk of transmission of viral hepatitis through breast milk. So it's completely safe for someone with viral hepatitis to breastfeed their child. Okay. Again, it's not just another pictorial representation of how the transmission happens. Either to begin with, we might have an infected embryo. Of course, this I didn't mention. Any interventional procedures, amniocentesis or biopsies from the chorea, anything which can breach the barrier can transmit the virus. Microtransfusion of blood during labor. Of course, I've already mentioned about placental infection and the transplacental leakage. All these can cause the transmission of virus from the mother to the fetus. So what are the risk factors? So the mother can have Hep B or Hep C, but what are the risk factors which can definitely cause a transmission of the virus? So HPEAG is a protein. It signifies a high infectivity in the patient. So its presence correlates with an increasing viral transmission rate. So whenever you see a patient who's HPEAG positive, okay, it denotes either they've had a past infection or they are actively infected now. So what we need to do next is do an HPEAG level and do a HBV DNA quantitative. Okay, these two put together will tell you how infected the patient is. If the patient is HPS-AG positive and the HPA-AG is negative and HPV DNA is negative, then what happens is it means that it's a past infection. But if both of them are positive, then they are currently infected, and of course they need to be treated. So that is so. Where any mother with HPE-AG positive means that they are a high risk of transmitting the virus. More than that, maternal viral load, HPV DNA quantitative levels is important, and the degree of viremia and the detectable viral load is a significant factor. And of course, you should also know that there are genotypes for hepatitis B, of course, which is not much relevant. Again, kind of similar risk factors in hepatitis C, HIV co-infection in both, again, maternal viral load, and a whole lot of invasive diagnostic testing may contribute to increased risk owing to disruption of the normal tissue barriers. So what do you do? So someone's got HPS-AG positive. So what do you do to to the patient and the child? So there was a big meta-analysis suggesting that the mother should be given hepatitis B immunoglobulins just prior to delivery, so that she sterilizes and then the viruses doesn't get transmitted to the newborn. But again, one Cochrane analysis, which puts all the meta-analysis together, suggested that there is no great evidence for that. So once a child is born, okay, now of course this all has become universal. We all know that everyone who's born, at least in our country, any childbirth born in a hospital in our country gets their 3 doses of vaccine from day 0. But if a child is born to a hepatitis B positive,
we request all the participants to remain muted unless asked to unmute themselves. Please do not disrupt the speaker in between the session. Thank you. Sir, please, you may continue.
So we know that the hepatitis B vaccine is being given to every child today. I think that's been happening for about 17, 18 years now, or even more slightly, not more than 20 years. But Hep B vaccine is given to every child. But if a child is born to hepatitis B positive mother, then what we need to do is within the first 12 hours, they should get an IM injection of hepatitis B immunoglobulin. So what's an immunoglobulin? It's a plasma-derived product from pooled HPV immune donors who have high antibody titers. Okay, so you check the anti-HPS level of these patients. The anti-HPS level of anything above 10 means that you are immunized adequately. Okay, some will have 100. Of course, I haven't checked for a long time, but mine is over 1,000. So. So I might be able to donate my plasma from which an immunoglobulin can be produced, which can be given to patients. Of course, in this case, it'll be a newborn child. At the same time, what we have to do is we have to follow up with the hepatitis B vaccine. Okay, so that is done to the child. So you give immunoglobulins plus hepatitis B vaccine if the child is born to hepatitis B mother. So what do you do to the mother if she is HPS-AG positive but the viral load is negative? Of course, in the current evidence is that don't do anything. There were some big studies on giving immunoglobulin to the mother itself, but that's been disproved now. But there are patients where there is failure of immune prophylaxis. Okay, breakthrough infection is defined as a persistent hepatitis B virus in newborn despite vaccination or hepatitis B immunoglobulins. And why does that happen? If the maternal viral load is very high and the HPS-AG is positive and we fail to identify that, and if there is delayed vaccination or inadequate vaccination, vaccination needs to happen on day 0, the first month and the 6th month. And if there's a delay or if there's inadequate dose, then obviously that can lead to a failure of immune prophylaxis. And of course, vaginal delivery, as I said earlier, may cause failure of immune prophylaxis. So what happens in the mother? So the child is very clear. We whatever be the case of the mother, the child should have immunoglobulins and vaccines. So what happens in the mother if her antibody, if her viral count is very high and she's HBsAg positive? Today, several antivirals are available for treating mothers in the antenatal period. Okay, and we now know that the late second trimester or the third trimester is safe as fetal organogenesis is largely completed. Thus, the risk of teratogenicity is reduced. Okay, so this is used. Of course, it's not 10 power 5. This is 10 to the power of 5 copies per ml. Maybe I don't know how to put it 10 to the power of 5. I think the 10 bar 5. So if the maternal level is more than 10 to the power of 5 copies per ml, that's a huge number. But still, if it's that, then the mother should be treated, and I'll tell you what drug she needs to have. It's important to also note that patients with chronic Hep B can have reactivation, and they have to be closely monitored. Why? Because there is a lot of immune modulation that is happening during pregnancy, which might decrease immunity, which can cause reactivation of the virus. So what drugs do you use? Of course, these are guidelines given by various organizations. AASLD stands for the American Association for Study for Liver Diseases. EASL stands for European Association for Study for Liver Diseases, and PASL is Asia Pacific. Again, they've given at what level the virus needs to be given. And if you see, universally, all of them given the late second trimester and in the third trimester. Of course, the drug of choice today is tenofovir. And the new drug which is in the market now is called the tenofovir alafenamide, which is 25 milligrams, 1 tablet a day, which is very, very straightforward. And when do you stop treatment? This is up to between 4 to 12 weeks. Okay, most importantly, the mother can breastfeed the child when the antiviral drug is being given. So not to stop breastfeeding. Breastfeeding is not contraindicated at all, so that should happen. The drugs can stop 4 to 12 weeks after delivery, and then be monitored by HBeAg and HBV DNA levels. So the drug of choice is tenofovir. So to summarize, you screen all mothers for hepatitis B positivity, and if they are negative, obviously no evaluation is required. And if they are already vaccinated, not to worry. If not, they have to be vaccinated. If they are positive, then we have to look at the HBV DNA levels and the HBeAg levels. And if the level is more than 10 to the power of 6, then we know that there is an increased risk of vertical transmission. In that case, the mother needs to be treated in the third trimester with antiviral, preferably tenofovir, somewhere between 28 to 32 weeks, and continue up to 4 weeks. And the child should have a hepatitis B immunoglobulins and hepatitis B vaccination at the time of birth. Now, of course, that is all about hepatitis B. Hepatitis C, so we have to understand one thing. Of course, we've done a lot of community work, and we've in fact published our paper on the prevalence of Hep B and Hep C in our country. That's from the South India, and we had close to 20,000 population study. And what we've realized is that the prevalence of Hep B and Hep C is varied across the country. In Tamil Nadu, we looked at about close to 15 districts, and the Hep B was prevalent, and the prevalence rate was about 2%, while Hep C was only about 0.5 to 0.7%. While the hepatitis C virus infection in North India is predominantly high. Punjab is extremely high, very, very high of Hep C prevalence. Of course, there are lots of pockets in Northeast India where Hep C prevalence is high. So the prevalence of Hep B and Hep C is varied even across our country. Of course, in the Western world, Hep B is almost getting eliminated because of the active vaccination schedule, which has happened very many years ago. But we are yet to get there. But I think maybe in the next 10, 15 years, we'll get there. But by the time, Hep C will be eliminated because we have fantastic vaccines. But nevertheless, I have to say I've not seen a Hep C infected mother, but maybe in the North India, we might be able to come across Hep C infected mother. So it's quite essential that all mothers be screened for Hep B and Hep C. In fact, I mean, anyone who's going for any kind of procedure should be screened for Hep B and Hep C. And still, I see doctors screening patients only for hepatitis B. They think that Hep C is non-existent. So I think every mother should be screened for Hep B and Hep C. We know that co-infection with HIV is an extremely high risk for vertical transmission. There is no, but there are few papers which are suggesting that there is no evidence that HCV can be reduced by LSCS. But nevertheless, I think anyone with Hep C should be offered a cesarean section and not vaginal delivery. As of now, there are no clear recommendations as to when to treat the mothers with DAA. DAA means direct-acting antivirals. There are, as I said, there are some amazing drugs available these days. Various combinations of Sofisburger is available in our country. Of course, it was quite expensive when it came up. Now it's extremely cheap. A lot of governments doing it even free of cost. Tamil Nadu, you can get it completely free of cost. Otherwise, it costs about 7,500 rupees per month, and you only need to take it for 3 months, and it completely eliminates the virus. So, but as of now, we don't, whatever be the viral load, we do not give the tablet to the mother because we do not know what is the cause. Does it cause any teratogenic problems in the child? We do not know because it's a fairly new drug. So we just leave it as it is and then treat the mother after delivery. So what happens to the child? The children are not to be treated with DAAs. Why? Because they can have a spontaneous clearance. Over 50% of them can have a spontaneous clearance because of their immunity, and they should just need to be followed up with the yearly HPV DNA levels. Ideally, after 3 years of age, if they are still positive, they should be treated. If not, they would just need annual checks. But there are also lots of patients who've been chronically Hep C positive, and pediatric children have been transplanted because of Hep C cirrhosis. So to summarize, Hep C patients, mothers again should be tested. If positive, you should not do anything, and then followed up postpartum. Again, breastfeeding is not contraindicated in these mothers, and if they're still positive after delivery, then direct-acting antivirals can be given. In pediatric patients who are born to Hep C mothers, they will be Hep C positive, but only for some time because they're going to clear the virus automatically. We follow up these children for up to 3 years minimum, and if they're cleared, we leave them. If not, after 3 years, we start them on some antivirals. So friends, to conclude, I know that was short. We deliberately kept it short because it being a Sunday evening. We have to understand that pregnancy offers an excellent opportunity to begin HPV eradication or elimination. And then I think it's all of our duty to work towards Hep B elimination. Risk by acquiring chronic Hep B infections greatest in the perinatal period, with up to 90% of infected newborns becoming chronic carriers. So, routine antenatal check, neonatal immune prophylaxis remain the key measures to reduce the global HPV burden. Long-term follow-up of the offspring is currently lacking and would be essential to demonstrate the long-term safety of in utero antiviral treatment. And I think it's important. I know there's you're doing a lot of projects and research, and I think it's so easy for us to do some research and project and publish some papers on the prevalence of Hep B, because when I was doing this talk, I hardly found many papers from India suggesting the prevalence of hepatitis B or C in our country in mothers. So I think AMSA India should take up, sorry, I don't know why I put WMC, but AMSA India should take up some projects. I'm happy to help and guide, and we should be able to publish a few papers. If just 10 or 20 of you join together and find 100 mothers, in and around your community, or go to an obstetric hospital and find out about their about your Hep B or Hep C status. We can get a questionnaire done, and that would be an amazing data. 20 of you getting 100 patients will be 2,000 mothers, and when we know them, it's very, very good to publish these things. So. So my humble suggestion and humble request is, please take up any projects like this, and I'm happy to help. And thank you for hearing.
Thank you so much, sir. For all the participants, we are open for questions now. If you have any question, you guys can ask yourself also, and we can ask on your behalf as well. So any questions, guys? Right. So, sir, I will ask the questions on their behalf. Right. So,
Akansha, if I may interrupt you, one of the participants have raised their hands. Samarth, would you like to unmute yourself and ask your question? If you're not comfortable with that, you could type out your question in the chat box and we will speak it out for you. Sir, what you said regarding research and taking it up, I think that is going to be the next step for Pact to Protect against hepatitis. We started last year, and awareness, we're doing it. But that should be the next big step for Pact to Protect, hopefully with your help.
No, we should. I think me being in this profession for a fair bit of time, number of people who are unaware. I think awareness is the key. What I will do is I will speak to the alliance and see whether we can do something on a large scale. So straight away you get some international recognition. I have connect with the WHO head of the CRO region. In fact, he sits in Delhi. So we should be able to see whether we can put certain things together. But before that, we have to show something that we are really interested
Absolutely
in taking this project forward. So as I said, I think I have to admit that I've not concentrated much on vertical transmission. I've done a lot of community work. We go screen and we teach these patients. But I think there are multiple things which you can do. One is obviously vertical transmission, mother to child transmission. Two is IV drug users. Three is prisoners. There's another interesting thing which you could do is you can send out a questionnaire to all 3,000 of your people and ask them to write unbiased about what they know about viral hepatitis. We can get a questionnaire. Then you'll be surprised to know that the awareness of viral hepatitis. There are enough papers on. End of the day, it needs to come as a publication. So that's a quality that is required. You can look at the healthcare professionals, your nurses. Get 1,000 nurses and find out what is their knowledge on viral hepatitis. You'll be surprised. That'll be a great publication. So when you do such things and when you present it to the government or the authorities and tell them, boss, this is dismal. This is what is required. You have to teach these people. There are modes because they just need to teach pockets of Anganwadi workers. And then they'll take it to the families, and then they'll take it to the nurses, so on and so forth. So there is a system in place in our country. It's just that we have to use that system to and exploit it to our benefits.
Right, sir. Sir, we have some questions from the participants in the chat. I will just read them for you. Okay, so one of our participants wants to know that if a fetus has chronic hepatitis, should the abortion be done or medication?
Fetus or the newborn? How old the
fetus?
Come again? Sorry, sir. Repeat the question again.
Sure, sir. So the question is, if fetus has chronic hepatitis, should the abortion be done or medications are sufficient?
No, no. Why would you? So first thing is you would not know whether the fetus is infected or not. Correct? How would you know? There are no ways to find out if the fetus is infected. Okay,
That is correct.
we only know if the mother has got a high viral load of B or C, then that can get transmitted. Okay, but in the current scenario, I would not abort any child because the drugs are amazing. The transmission can be interrupted by immunoglobulins and vaccination for hepatitis B, and amazing antivirals are available for hepatitis C. So I don't think they should be aborted. They should continue because if the mother has got Hep B or Hep C, she's going to be Hep B or Hep C forever, right? And she's never going to have a child. So, I mean, as I said earlier, hepatitis B is treatable but not curable. Okay, of course, Hep C is curable though, but hepatitis B is not curable. So, abortion should not be done and cannot be done.
Correct, sir. Sir, Sarth wants to ask, why does the prevalence remain so high in India, even though we have so active immunization programs in place? In Western countries, not all are as enthusiastic about vaccination, but even after having programs, the prevalence of hepatitis is very high in India. Why is that?
So, as I said, hepatitis B vaccination has been happening as a national program only for the last 20 years or so. Okay, it is not happening. It did not happen prior to that. Okay, so I don't know the exact year, but it's 2002 or 3 or something like that. But so what happens to the to the men and women born prior to 20 years ago? So they do not know their vaccination status. Okay, only children born after 2000 or maybe late 1990s know their vaccination status. So all these guys have erratic practices, sharing of personal items, sexual practices, so on and so forth, can lead to the virus transmission. That is why Hep B and Hep C is high. Maybe in 20 years, 15 years time, maybe the prevalence rates will come down, but definitely it's going to take some time and aggressive vaccination. Number one. Number two is we are not bothered about vaccination. Health is never in our radar until one of our family members get infected. So that is also another problem. How many? Just you should take the survey. How many of the doctors would know their Hep B and Hep C status? You'll be surprised. Of course, if you take 100 doctors, I can tell you 75% of them will not know their Hep B or Hep C status. Okay, so that is the problem in our country. That is why it is so high. So if the doctors are not aware, how are they going to take care of their patients? Right. So every patient coming into the hospital for surgery or any procedure, invasive procedure, should have their Hep B and Hep C status checked. Okay? That does not happen in our country. So that is why the prevalence is high.
Right, sir. Sir, along with that, even medical students, they do not have the awareness of getting the vaccination.
I thought you guys, they all should be vaccinated and you should have a certificate before entering college. Is that not true, right?
No, sir.
Oh, in our college, from Maulana Azad Lok Nayak, our teachers actually specify that we will not be allowed to enter the clinical postings without the vaccine. Even though we have had it before, we would check the titers and get it done again. It was compulsory for us.
So that's a good practice. I think that needs to be. It's a good thing. No, you should go and maybe AMSA should take this up and write to all the medical colleges and ask for Hep B and Hep C testing. I've approached the director of public health in my state and said, boss, we need to go check everyone. Give me permission. I'll go do the checking, and you can help me. He's saying, boss, we don't have money. Don't even bother doing any of these things. And that is the status in our country.
Right, sir.
Someone's asking the long-term side effects of hepatitis B treatment. Correct? Is that the one?
Yes, sir.
So there are no long-term side effects. The latest drug which is available in the market today is tenofovir alafenamide, which is a 25 milligram tablet. In fact, the earlier TDF tenofovir plain was had some kidney problems, but now that has gone away with this tenofovir alafenamide tablets. The again, the guidelines as to how long we treat these patients varies. If so, what I would do is that if I know that a patient is going to come back and is very clear with follow-up, then once I treat them for 2 to 3 years, and if there are no other risk factors, there's no cirrhosis, there's no family history of hepatitis C, and he does not have any other risk factors, then I stop treatment and I ask them to do HPV DNA levels every 6 months. Okay, if I see someone from the village who comes and who probably I feel is going to be erratic with follow-up, then I do not risk it. I just ask them to follow up with the medication lifelong. Of course, you have to understand that the patient's got cirrhosis or even fibrosis in the liver, then they will have to have antiviral treatment lifelong. Why? Because cirrhosis is a very, very risky condition where cancers can happen, and a virus on top of it, a high viral load on top of it, can also lead to cancer. So, we patients with viral hepatitis and cirrhosis, we carry on medications lifelong without any problem, and even after transplant, actually, unless they become HPSAG negative.
Right, sir. Sir, Gautam wants to ask, why is there transmission of hepatitis B by breast milk from mother to child, as the enzymes present in GIT can destroy the virus?
Gosh, I don't know that enzymes can destroy virus. I don't know whether that's true or false. But I did not say that there was a transmission of hepatitis B virus from the breast milk. In fact, they said the HPSAG was positive and the virus was found, but they found that the virus was not transmitted. Maybe you're right. Maybe the virus get destroyed, but if there is a crack in the skin on the nipple, or if there's a crack in the skin or the mucosa of the mouth, then there is a transmission directly there at the blood level, at the buccal level or at the nipple level. Then the virus can get transmitted. There is no hepatitis B and C does not carry a fecal-oral transmission. You have to understand that. Okay, it's a blood and body fluid transmission. So ingesting a virus is not going to cause Hep B and Hep C. That is why breastfeeding is not contraindicated in pregnancy with Hep B mothers as Hep C mothers.
Right, sir. Sir, a participant wants to ask, can you please guide us for research on hepatitis and its related aspects?
Right. So, for the multiple things which first is to begin with the seroprevalence itself. There are hardly any papers. In fact, we published the largest seroprevalence data from India. There is hardly any seroprevalence data across the whole of India. So you can divide the wherever you are, you can divide into pockets, and you might be able to collate all of them. So you might have to do screening in the community and put all the data together. So to understand the seroprevalence of Hep B and Hep C, that will be a very good paper to publish. Number one. Number two is on all the other verticals which I said. Mother, you can choose just all the pregnant mothers. You should go to your close obstetric hospital. Pick out 100 mothers randomly, check their Hep B and Hep C status. Likewise, you can collate all the data across various centers. You'll have 1,000 mothers with Hep B and Hep C. That you can do. I think what is important is the prevalence is important in our country. We don't have data on seroprevalence. Okay. Likewise, you can test the knowledge of paramedical people, ambulance drivers, nurses, on their knowledge on Hep B and Hep C. That is again will be another amazing paper. So you just need to fill a small question. You have to start something simple. If you think something really big, it's never going to happen. Start simple, and then when it gets published, you get all the encouragement, and then you can get on and do so many other things. That is number 3. Number 4, which is extremely important, is the level of the anti-HPS levels in people who've been vaccinated. So what you can choose, which I've been trying to do, which I'm not able to do. Again, the problem is you need funding for all these things, because you need to do blood tests. So for people who've been vaccinated 15 years ago, they say that 3 doses of hepatitis B vaccine is good enough for lifelong immunity. Okay, and we know that an anti-HPS level of more than 10 is at least required. If it's under 10, then we need to have a booster dose. Okay, so you can check on the anti-HPS levels of about 1,000 doctors or 1,000 people who've had vaccines 15 years ago, and you can say that, well, this is not good enough. We need to have a booster dose once in every 5 years or once in every 10 years or something like that. So that is one. Of course, now we're working on. In fact, we just published a paper along with the ICMR and the government of India on the health economics. What is the cost of vaccination, and what is the cost of managing chronic liver disease secondary to viral hepatitis? It's humongous. The cost of vaccine is only $400-500, all 3 doses put together. But the cost of managing Hep B and Hep C cirrhosis or HCC cancer is very high. So you can put that data together, and I can share the paper with you. It's an amazing paper, and that can be the health economics is quite important. The other thing which we can concentrate on, health delivery. So is how is the vaccine delivered? Is the vaccine getting to everyone? Who's being treated, who's not being treated, what happens in families with hepatitis B, hepatitis C, in lower socioeconomic status, higher socioeconomic status. It's just vast, So what we could do is, if you're really interested, we can put 10 topics, and then we can have teams working on these 10 topics, and simultaneously produce some good papers.
Right, sir. So next question is, given that not many doctors are aware of their Hep B or C status, how do the doctors ensure their safety when carrying out the delivery of a Hep B or C positive patient?
So obviously, first thing is they have to know. Say, for example, so this is PEP, this is post-exposure prophylaxis, right? So if someone is going to deliver, or someone is doing surgery on an hepatitis B patient or a hepatitis C patient, ideally, as you rightly said, the doctor should know his or her own status, because he would never know if he gets his infection from the patient or he's already had it himself. Okay, so if he gets a prick, if he gets a stab injury, or if there's a blood splash, then straight away a blood test needs to be done for the patient and for the doctor. If the patient is negative, then it's not a problem. If the patient is positive, then obviously you have to check if it's hepatitis B, then you have to check his EAG levels and his DNA levels. If it is hepatitis C, you have to check his hepatitis C RNA levels. For the doctor, if the patient is hepatitis B positive, then he has to have his immunoglobulins straight away, okay, and then wait and watch. You send the bloods off, have immunoglobulins, and then wait and watch, and then you can do sequential testing and check if you're still being negative. Okay? If it is hepatitis C, and if the counts are high, what you could do is the hepatitis C will not show up straight away. If you have a blood splash today, tomorrow you're not going to become hepatitis C positive. So what I would do is I would test it, in 3 months' time and 6 months' time, and see if you become hepatitis C positive. If positive, all you need is those tablets, Sofosbuvir-based tablets for 3 months, and the virus will be completely eliminated. So of course, that is why we have to know the status of the patient before they put onto the table. Be it a delivery, be it a dental procedure, be it any minor procedure, B and C should be tested before they go on to the table. But of course, we have to understand that the chance of transmission, though it is higher than HIV, the chance of blood splash transmission is higher than HIV. It's only under 1%. So not every positive patient is going to give you blood unless the viral load is extremely high. Say, for example, if there's a blood splash on my hand, I cannot get hepatitis B unless there's a breach in my hand. Okay, so that's we have to understand that. So, but nevertheless, you have to be safe. Universal precautions, double gloving. So when I transplant patients with hepatitis B or C, I always double glove. Of course, I have my loops or goggles on most of the time, and of course, head to foot we are covered. We make sure that we don't get in contact with blood.
Right, sir. Sir, next question is from Sneha. She wants to ask that, what are the new guidelines set in treatment using antivirals for prevention of mother-to-child transmission of hepatitis?
So as I said, antivirals, if the viral count is HPV DNA is high in the mother, third trimester we start hepatitis B anti-tenofovir for hepatitis B in the third trimester if the viral count is high, right? For hepatitis C, we do not do any treatment. We just wait and watch. Okay, we let the child be born, and then you can retest the mother, and after that you can start direct acting antivirals. Okay? These are the guidelines to be. So please do not start any antivirals before the third trimester because they can be teratogenic.
Right, sir. Sir, next question is from Vrinda Pahuja. She wants to ask if status of vaccination is unknown and anti-HBs titer is sufficient. Is vaccination recommended?
It's not recommended. So for a low risk, we are high risk. You have to understand, doctors are high risk. There is no evidence though. They all suggest that any anti-HBs levels of more than 10 is good enough. Okay. I think 100 is a good number. Again, there's no evidence for that. I think it's just your mindset that 100 is a bigger number than 10. So if I see a doctor with an anti-HBs level of 10, I would say just get a booster dose. You just need another 1 milligram of 1 ml of an antiviral vaccine. Just to boost a dose. We can do it once in 5 years. Once in 5 years, you take your anti-HBs levels and you can have a booster dose. But if it's sufficient, if it's, as I said, I checked my anti-HBs levels, it was more than 1,000 actually. That was, of course, 6-7 years ago. So I'm not worried about a booster dose at all.
Right, sir. Sir, that was the last question for today. If any participant has any more question, you can unmute yourself and ask, and you can set in the chat as well. Someone wants to ask something, or we can end the session.
Someone's asking about ETMCT. I have no idea what it means. ETMCT plus. What's ETMCT?
Sneha, can you unmute yourself and explain your question a little, please?
Gosh, you are very clever.
Hello, sir.
Hi.
Sir, ETMC Plus was actually a form of a regimen kind of a thing which was implemented by WHO in 2016 for the region of America. And after implementing in this region, there was a very sharp fall in the cases which were reported. ETMC Plus was actually a proposal to deal with cases of HIV, Hep B, Chagas disease, and syphilis along with it. So can India also take up, is there any possibility for India to have a look at it and implement it in the same way how the American region has taken success in it?
Please forgive my ignorance, but still, I don't know what the components of ETM-CT plus is. You know, what kind of program is it? Is it medication or related, or is it what
So
kind of program?
it is propagated as a holistic approach along with medication and the government schemes together. But as we know, HIV has taken a lot of focus in India, though Hep B is actually more effective. So is there any possibility for it to happen in near future?
Yeah, I have to admit that we have not heard of it. I've had enough meetings with the World Health Alliance and the WHO, and we've not heard of this kind of program at all. So, which means, so maybe this was, I think it developed America, maybe it was not there, you know, it was maybe for South Chagas disease. I don't think Chagas disease was in North America, maybe for the Amazon, Chile, that kind of area, you know, Peru, maybe it was there. I do not know.
North America, but it is actually proposed for the American region as a whole. So different hotspots were identified with different focuses. So it was.
I'm sorry, Sneha, I wouldn't know anything about that, but I've not heard of this. I mean, me being in viral hepatitis for a fair bit of time, we've not heard such a program, and WHO guidelines do not suggest anything in these lines. You know, even the National Viral Hepatitis Program Control Program does not suggest any of these guidelines suggesting ETM-CT plus. So I don't believe it's going to come in the near future.
Thank you for the clarification, sir.
Thanks, Neha.
Thank you so much, Sneha. Thank you, sir. Is there anybody else who wants to ask any question? You can unmute yourself and ask.
About high doses of DAA. So
Right.
DAA is direct acting antivirals, and that is given. That is obviously is you know, for hepatitis C. There is no dose related. So of course, there's only single dose which is available. In fact, it just comes as at times it comes as a single tablet. So as I said, it's one tablet a day. It's 400 milligrams and 80 milligrams of soft and velpatasvir or various bacla, velpatasvir plus soft. It's all various combinations are there these days. And depending on the genotype, we should know that hepatitis C has got 6 genotypes, and based on the genotype, the combination will change. So most of the time it comes as a single tablet itself. So you just need to take a single tablet for 3 months at a stretch, for 90 days at a stretch, the virus will completely go. But I know some of them take it for 6 months. I've known patients take it for a year, scaring that the hepatitis C will come back. There are no major side effects secondary to these antivirals being used on a long-term basis.
Right, sir. Right. I think we are done for the question and answer round, and we are getting amazing feedback from all the participants. They are really, really happy. We are actually honored to have you with us. And this was such an important topic. And actually, we didn't have this amount of information with us before this session, sir. Thank you so much for that. Okay, I request all the participants to please switch on their webcams, and we will take a quick picture with sir, and then we can end the session. Please switch on your webcam, everyone.
How do we do that with 100 people on board?
So we can take a screenshot of the participants panel.
So Wednesday we are doing another session, is that right?
Yes, sir. 23rd. Yeah.
Oh, Sunday evening, all of you are bright and cheerful, despite me boring you. It's very good.
Parikshit, are you on the chat? Are you here, Parikshit?
Yes, I'm here. Yes, I'm here.
Okay, take the screenshots, okay? For when
yes.
the camera. Okay.
Just give me 1 second.
Trying to do it on my Mac, but it's not going to. I wouldn't know how to do that. There we are.
I'm trying to click on.
Super. So let's do some work, guys. Let's do some projects.
We are in, sir. We all are in.
All of you just need just small work, just 10 patients, 15 patients, and all of you put together, and all of you have 1,000 patients. So
Correct, sir.
very easily it can be done. And make sure it's published, and make sure you put my name on it.
Definitely.
Parikshit, have you taken the photograph of all the screens?
Yes, ma'am, I have.
Perfect. Akansha, could you announce about the attendance form and the next session we have?
Sure, ma'am. Right. So, guys, Parikshit will be sharing the screen with the QR code of the attendance form. You all can scan it and give your attendance. Parikshit, can you share the screen, please?
Yes, just give me 1 second.
Yeah.
Is my screen visible?
Yeah. So this is the QR code. You all can scan the QR code and give your attendance. In case you have any difficulty in giving the attendance using the QR code, DM us. We will send you the form that you can fill to give the attendance as well. Yeah. Okay, guys, we have a very exciting announcement coming up regarding the debate that we have on 26th. We will be giving all the rules of the debate on the group today, and we are expecting all of you to participate. So yeah, and in case you guys have any doubt, do not hesitate to reach us, and do not forget that we have cash prizes for the winners of the debate as well. So do participate. The form, it's open for the next 1 hour. You can give your attendance within that time limit, and we will share the form if you cannot scan the QR code. DM us.
Maybe a bit about the next session we have on 23rd.
Yeah, sure, ma'am. So the next session we have is on 23rd. We have Dr. Vivekanandan with us as our speaker, and the topic that we will be discussing about is liver transplantation is in a patient who is suffering from viral hepatitis. So it's a very interesting and it's a very technical topic, and we are hoping you all to see that. Yeah, that's pretty much it for the next session.
Hoping to do on that day was talk about, of course, viral hepatitis transplantation is it's a very interesting topic. So I can just start off with indications, contraindications, steps, blah blah blah, and then let's touch on viral hepatitis a bit. Because viral hepatitis for transplant alone is a very very small one. I think for medical students, understand why transplant needs to be done, when it needs to be done, and how it needs to be done might be interesting. If I do that, will that be okay? And of course, we'll touch on viral hepatitis also.
Yes, sir, sure.
Is that it? Yeah.
Yeah, so that's it from for the session today. Thank you so much for being with us.
Yes, sir. Thank you so much. We're just going to let the session be open for another 5 minutes so people can scan the code and mark their attendance, and then we'll close.
Lovely. Thank you very much indeed. I'll see you on Wednesday.
Thank you, sir.
Thank you so much, sir. Bye, sir. Ma'am, since a lot of participants are not able to scan the code, so should we send the
link as well
in the chat?
We've already shared the link in the chat.
Yes, it has been shared by one of the participants only, which is thank you so much for doing that. And this code can be used for people viewing us from YouTube. So we're still going to let it be open for another 5 minutes, and then we'll close the meeting. Thank you all for joining us. Please make note you have to join all 3 sessions to get the certificate. So we're seeing you to next time too. And make sure to participate in the debate.
Those people who are done with the form, they can leave the meeting. There's no need to wait.